Уважаемые господа,
Dear ladies and gentlemen,
я прошу, продолжить.
I would like to continue.
На следующей очень интересной, актуальной теме.
We have an interesting subject right now. The upcoming panel. Volker Daman is the next moderator for the panel. He is the lead on biomedical research of the European Space Agency in Cologne. Dr. Volker is one of the most active participants of providing medical support on ISS research. He is an author of standard development for health and procedures to sustain physical activity in space. It is a great honor for me to introduce Volker. Please, your turn.
Thank you, Valerie. As usual, those sessions get you a little bit by surprise. So we also have to improvise, but I also would like to do it a little bit in the way that John has done it, a little bit more interactive talk show style, maybe, if I can do that. So the VIIP, of course, an issue that struck the community a little bit unexpectedly. And I think it's still not known if we have overlooked something in the past years, or if it's a new phenomenon that is related to the ISS environment or exercise regimes we have on board. But I think it's an interesting issue that brings together a big community of science, of operational people, fundamental research activities in all different entities. Or as we in the medical community call it, it's this eyeball stuff going on. So I just quote Bill Tarver, the head of the flight clinic in Houston, who gave a great presentation at ASMA this week or last week in Chicago. So what I would like to do is, in the time we have, to look at the issue from the different aspects, and I think we have a beautiful panel here with us from the international partner side of the house, but also representing different elements of science and operations. So I would go right into it and would like to ask Ben Levine to give us an overview of what he thinks from a physiological, scientific, clinical perspective we are dealing with, and how we should enter and connect the dots to grasp what is really happening. Ben.
Thank you, Volker. So, for those of you who don't know me, I'm a cardiologist and a cardiovascular physiologist. And I take care of sick people as well as do research in hydrostatic gradients and the adaptive capacity of the circulation. And I was fortunate enough to work on SLS1 and SLS2 and put the catheters in for the CVP measurements. And as most of you know, the working hypothesis of the VIIP problem is that the loss of hydrostatic gradients, typical hydrostatic gradients, not just in the head to foot plane, but also in the front to back plane, are lost in space, and that causes a central fluid shift on both the arterial and the venous side. And particularly in people who may have subtle but common abnormalities of venous emptying, that may cause an increase in cerebral venous pressure and an increase in pressure in the back of the eye, and that may lead to a variety of adaptive changes altering visual acuity. The model has been that I think many of the clinicians who deal with intracranial hypertension have used this as a model, though I will say that the single most important feature of intracranial hypertension on Earth is that people have a headache. That's the most common symptom. And it's not part of this VIIP syndrome. People don't have headaches. So what I want to emphasize is that we've been fooled before. remember, before Drew Gaffney flew on SLS-1 with the CVP catheter, we were all 100% certain that CVP was going to go up. There was probably not a person on the planet who thought that CVP was not going to go up when we went into space, and it went to 0. So we've been fooled before, and I think everybody needs to be very careful about jumping too quickly, about assuming the pathophysiology until we get the data. And we have, at least within the NSBRI, we have 2 invasive experiments where we will directly measure intracranial pressure. In a study that I'm running, we're taking patients who have direct access into the intracranial compartment, people who have Ommaya reservoirs, and we will study in great detail. An Ommaya reservoir is a little port that is put in certain groups of patients to deliver drugs into the brain, sometimes prophylactically in people who have completely normal brains. And so we will directly measure pressure during a variety of maneuvers, including exercise and CO2 on the ground, and then during parabolic flight. So that's coming. And for those of you who are not clinicians, and even for those who are, remember the first rule of taking care of an emergency is if a patient looks like they're dying, is take your own pulse, right? So everybody needs to, I think, should take a deep breath, wait for the data to come out, and then we can start making some decisions. And people are not dying from this problem. So visual acuity is changing, for sure, but it's correctable. And I think that we need to take this one step at a time. And that emphasizes the third point that I would like to make, is that all the agencies that are represented here have gotten many projects that are taking place looking at this visual impairment problem and doing a variety of different studies. And it becomes critical to coordinate those activities. Gary Strangman from the Sport Medicine team at NSBRI in the audience and I put together a program where we tried to pull together, at least within the US, all the VIIP investigators, and that was extremely successful. We set standards, guidelines for how to measure invasive pressures, because if we're going to do that around the world, everybody needs to measure it the same way, so that we can interpret the data together. That's what's important. And those standards are being published, and our colleagues at Johnson Space Center are developing very clear and specific guidelines on non-invasive measurements, and everyone needs to follow those. And if you don't want to follow them, please tell us why, and we can adjust them. And I won't talk about another really neat strategy that Dorit Donneville has come up with to help coordinate all these efforts. I'll let her talk about that, but I seriously encourage everybody, all the organizations and agencies that are participating in this problem, to participate in that, so we can discuss on a regular basis, be aware of the data that are coming out, and evaluate the data at its earliest stages.
Okay, thank you, Ben. Well, then let's go right away to Dorit and go into the science program.
Thank you. So I represent the National Space Biomedical Research Institute. I'm fortunate enough to be Deputy Chief Scientist, and I also lead a group called the Industry Forum, which engages the private sector. Most recently, I've been given the other task of corralling the cats, if you will, of bringing together all the folks who are working on VIIP and tagging up with the NASA and efforts that are going on. I wanted to say that NSBRI is very cognizant of the fact that this is a very urgent medical issue, but I do applaud Ben in saying that we need to be cautious and proceed, as Peter Norse mentioned previously, in a scientific manner. It's very important. We are also excited about the opportunities for studying a brand new syndrome. This has not been described before, and it's an opportunity for physiologists. It's an opportunity for the entire scientific community. I can't tell you how many clinicians, neurointensivists are really excited when we talk to them, ophthalmologists, et cetera. Vascular biologists, neuroscientists, people who are studying the retina, people who are studying glaucoma. They're all very fascinated and interested in this syndrome. So we have an opportunity to learn some basic physiologies. Biochemists are interested in the effects of nutrition and salt and all those things. People who are studying the effects of the environment, for example, increases in CO2 on cerebrovascular regulation, they're interested in this topic. So what this is an opportunity for us us to really make some significant headways across very diverse disciplines. And in addition, let me throw into the mix engineering. Many of the kinds of physiological parameters that we need to assess, we currently do not have portable, flyable, if you will, flight-ready capabilities. People have been working on measuring non-invasively intracranial pressure for a very long time. When you present them with an urgent problem, we need to fly something. It cannot be invasive. We cannot be doing lumbar puncture in space. There's concerns with regards to sending people with bolts. There may be issues with infections, et cetera. So it really presents a challenge to the engineering community and to the medical technologists to develop some new ways to do this. And so what we're doing at NSBRI is, as Ben mentioned, we're trying to bring everybody together across all these disciplines. And the way we do that is through the traditional granting mechanisms, but we run our program in teams, as you know. We actually add additional dollars to the team through awards to the team leadership. And what we're doing in the area of VIIP is we're going to start up, and when we've discussed how to structure this, we're going to start up a monthly WebEx telecon. And I'm thinking that we might want to do this early in the morning so our colleagues in Europe and Russia can participate as well if they'd like to join in. And what we might do is alternate months. 1 month it would be one group would present recent work, recent findings, and update everybody on what they have found. And then the next month we're going to have a sort of a journal club where a paper that was recently published or something of interest to the entire group might be presented. And I think by having an opportunity where people can tag up and follow up afterwards through a variety of communication methods, this will help the entire community make some sense of this very complex issue. And finally, let me just say that we are very fortunate to have a physical facility. Some of you were there on Wednesday night to see this beautiful facility. And what we have is the capability of bringing technologies in. And we invite all of you, each and every one of you, our colleagues in Russia, our colleagues in Europe, our colleagues at NASA, to come and look at some of these technologies. We're actually going to have on site the transcranial Doppler, the 2-depth transcranial Doppler. We have near-infrared spectroscopy. We're going to have the CCFP device. We have we're going to bring in some vision testing capabilities that are new. So some of our colleagues who are working in ophthalmology and vision health are also going to be able to come in and also standardize some of these protocols so that when we do procedures, clinical procedures, and also scientific collection of data, they're equivalent. I'll stop there.
Yeah, thank you very much. And that brings me a little bit into the technology side of the house. And I know it will be a challenge for Larry to talk about imaging techniques without images. But maybe you can still try to give us the essence of what do we really see when we do the imaging studies with our astronauts pre- and post-flight.
Thank you very much. Well, I think it's more difficult actually to follow Dr. Levine and his comments and talk about the MR imaging. I'm also intrigued by the concept of putting a superconducting magnet to deflect charged particles, because if you added some gradient coils and some radio frequency coils, you can actually probably do some magnetic resonance imaging. So maybe we can put our minds together on that. Because part of the problem that I have as a radiologist who's analyzed MR imaging on 27 astronauts is that I have just pre- and post-flight data, and I'm trying to draw conclusions what's maybe happening in the microgravity environment. So what I found after looking at 27 astronauts in terms of the imaging findings was that there was a component of posterior globe flattening that occurred in a number of astronauts. There was optic disc protrusion, which could be due to papilledema and increased intracranial pressure. There was distension of the optic nerve sheath, so the fluid around the optic nerve expands with increasing intracranial pressure. And there was also a optic nerve sheath kink. Now, all these findings have been published before in radiologic literature and have been associated to various specificity to elevated intracranial pressure in patients with idiopathic intracranial hypertension. And probably the most specific finding has been posterior globe flattening, which has 100% specificity to idiopathic intracranial hypertension. So if you were just looking at these 27 astronauts as just human samples in a terrestrial environment, if I was reporting this out as a radiologist, I would say that there's evidence of intracranial hypertension in a subset of these astronauts. But as these cases are occurring and being increasingly documented occurring in the microgravity environment, I think it's a unique environment. So I think going back to what Dr. Levine said, intracranial hypertension may not be the common denominator. Maybe it's in part a denominator, but there are other factors like venous factors that may be at play. And I think there's a lot of also cofactors at play. But just looking at it from a very narrow perspective as a radiologist, would have to say that intracranial hypertension is a component of what we're seeing. We definitely need more data. We need to be able to do those measurements in space to prove that there is elevated pressure going on after exposure to microgravity. Just this last week in Chicago, I presented some data on CSF production rate. Mm-hmm. And so one of the things you can do with magnetic resonance imaging non-invasively is actually to measure the CSF production rate. And we do that with a technique called phase contrast. It's a technique that we apply to angiography, but if you think about flow through the cerebral aqueduct as just flow in general, you can measure the magnitude and the direction of flow using that technique, and you synchronize that to the electrocardiogram. So you obtain a flow analysis of CSF flowing from the lateral ventricles to the fourth ventricle and back and forth over the cardiac cycle. And if you sum up the areas under the curve that are generated, the volume flux curves, you can actually measure the difference of CSF volume that is produced over the cardiac cycle. And so when I heard that one of the first astronauts that we studied had evidence of choroidal folds, I didn't really know what that was, and I had to look it up and talk to ophthalmologists to find out that either low ocular pressure can cause it or increased CSF pressure can cause that. It's due to a compressive stress of the globe. So one of the things I was concerned about just hearing that clinical diagnosis was that there was increased intracranial pressure. So from our first astronaut on, we started measuring the CSF production rate, the velocity, and collected that data. Only recently we start actually analyzing it and putting it together. So what I found, because I wanted to find out if there was any risk factors that we could probably describe for astronauts that may be more prone to developing these visual findings, visual abnormalities, and imaging abnormalities. So one of the criteria that we use to indicate whether there might have been exposure to intracranial hypertension was the presence of globe flattening. So out of the 33 studies that we performed at University of Texas here at the Health Science Center, we had 16 astronauts that had a repeat mission. And those 16, 14 astronauts actually had a perfectly normal posterior globe convexity. And That's important because that's our measurement. That's our measurement for 100% specificity to elevated intracranial pressure. So we looked to see what happened to those 14 astronauts on the repeat mission, and 2 of those astronauts, nothing happened. Their posterior globe convexity was normal on return imaging, and 12 of those astronauts had evidence of globe flattening, some of it which was pretty obvious, and some of it was probably more subtle. But if we looked at the production rate of CSF in those 12 astronauts that developed flattening on subsequent mission, it actually turns out they're in the normal range. My theory was that, our hypothesis was that if they had elevated CSF production rate to begin with, that would put him at higher risk, because you have this concept called the intracranial reserve, and that's the ability for the cranial compartment to undergo increased fluid shift but maintain normal pressure. Well, if you have a high rate of CSF production, maybe that will put him at less reserve capacity. And there's another equation, which is that intracranial pressure equals the pressure within the sagittal sinus plus the CSF production rate times the CSF outflow resistance. So again, going back to the model that CSF production rate may have something to do with astronauts developing posterior globe flattening on repeat mission. I should just say that every astronaut we study was already in the microgravity environment. But actually, the hypothesis that astronauts that developed flattening had increased CSF production rate that was much higher than normal actually turned out to be false. So we tested a hypothesis and it turned out to be false. But if you look carefully at what happened to the CSF production rate after they returned from flight, there was on average there was an increase in production rate. And in 4 astronauts, or 1/3 of the astronaut, there was a spike, 2 to 3 times the production rate that we saw at baseline. Now, by baseline, I mean that the astronauts we tested pre-flight were on average 911 days post-flight, so they probably returned to some baseline number. The astronauts that we studied post-flight were approximately 8 days post-flight, so more likely to reflect maybe a physiologic change that occurred during space flight. And one of the ideas I had was that if there is, and we have to still prove it, a raise in intracranial pressure, one of the ways the body can adapt to that, and I know we talked about the last meeting how adaptable the body is. If you look at that equation about ICP and CSF production rate, one of the things you can do is downregulate CSF production rate. So if you downregulate CSF production rate in the microgravity environment, what happens when you turn to 1G? Suddenly your CSF production rate is too low for 1G, so your body has to, again, readapt. So it readapts by increasing CSF production rate, probably higher than baseline since it was already downregulated. So this study, even though it failed to prove its primary hypothesis, may indicate another way of looking, another piece of evidence that may suggest that there is elevated intracranial pressure during space flight.
Okay, thank you, Larry. Brings me to our Russian colleagues. Until recently, we have also learned from our Russian colleagues that apparently the issue is not occurring, or not to the extent that we have seen it. However, I have learned that there have been also some monkey studies on bion flights before, which may have shown some indication of elevated intracranial pressure. So I would like to ask Valery Bogomolov and Dinesa to talk about the Russian experience on this issue.
Ну, прежде всего, я хочу сказать, что на заре космической эры еще
First of all, I wanted to say that in the 60s and early 70s,
была проблема,
we were faced with a problem.
связанная с оказанием медицинской помощи,
The problem was
внутричерепной гипертензии, связанной
how
с распределением
to
крови в
assist
организме в условиях невесомости в
a
краниальном
person in the case of hypercranial
разрабатывали методы дегидратации. И
pressure in case of fluid shift in microgravity.
немецкими
We were doing the studies with our German colleagues,
что по
and
повышению внутричерепного выдавления
then it turned out that the increase in intracranial pressure during space flight was not confirmed.
регулярной вене
Moreover,
на определенных стадиях даже ниже было фонового, чем
venous
и это было подтверждено
pressure was sometimes
американских
even lower
прямых и
than the baseline pressure, which was confirmed even by the American scientists.
50 лет
And
в полетах длительных
over 50-year span,
438 суток
when we had various duration flights up to 438 days, we looked at the changes in visual acuity, and we can tell you that we have not observed those changes in Russian cosmonauts. Moreover, visual acuity in longer duration flights would actually improve.
в ходе длительного, так сказать, полета становилось лучше.
In other words, vision would improve after a long duration flight, so we never considered it to be a serious problem.
Глазного дна при посадках на союзах
In terms of changes in retina and optic nerve, there were some indications of edema, there were some
перегрузками в момент приземления.
capillary bursts, but we attributed them to
И они достаточно
hard
быстро
landing.
проходили.
And all those things would resolve fairly quickly.
В основном у членов американского
Over the last
участия
few years, USOS
появились вот
crew members
те изменения, о которых было сказано.
showed the changes that we're discussing now.
Признаки повышения внутричерепного
We
давления,
identified some indications of the increase in intracranial
форма
pressure,
глазного яблока,
globe
деформация
flattening,
оболочек зрительного нерва. Достаточно серьезные и
optic
изменения.
nerve sheath deformation. So these are significant changes. Why did we not observe them earlier? Why do we see these changes only now?
Беспокоит.
This is the question that really concerns
Что
us.
изменилось
What has changed?
в космических аппаратах,
What has changed in space vehicles, mission plans, their durations, maybe activities that were performed? What changes did we have?
условия какие?
If there was a change in conditions or environment, what were they? One change is that the station has expanded. It's very large.
Больших размеров,
It has
соответственно, много
impressive dimensions,
различного рода электромагнитных
which means also there are a lot of
много элементов,
electromagnetic
которые могут внешне оказывать
impacts.
влияние на
There are a lot of factors that may impact
Изменилась
human body.
деятельность экипажа в плане
Also,
использования
work
средств
activity has changed,
профилактики и тренажеров.
particularly in the area of countermeasures.
Тренажеры,
We have sophisticated trainers, including
и резистивные
trainers and
упражнения
machines for
стали
resistive
основными
training,
в программе
and it is resistive
членов американского
training that became the main type of training that USOS crew members are doing. For the Russian crew members, it's a bit different. We're using primarily treadmill.
Вопрос, связанный с влиянием повышенного уровня углекислого газа на
We also discussed the impact of the increased CO2 levels on board the station. I do not believe that to be a significant factor because CO2 deviations have been observed in previous flights, and these changes do not support the theory that they cause changes in intracranial pressure. We also observed that when we did bed rest tilt studies, we saw that there were some changes in the venous drainage, which led to headaches and maybe some other symptoms. But that's something that resolved very quickly and didn't have any long-term effects. I think that when we talk about intracranial pressure, when we talk about intracranial pressure that is caused by fluid shift, it cannot be separated from the changes that are happening in the circulatory system, venous system, lymphatic system. When we look at fluid redistribution of fluids inside a body and all the compensatory mechanisms that come into effect, there may be some explanation for the phenomena that we're discussing now. So it's something that we need to study more. We also need to look at the loads that crew members are experiencing during flight. We should study what's happening to all the fluids inside the body and what's happening to the eyes. Study this further. I know that there is a requirement for the USOS members to do studies, to do research for VIIP. And as part of that, we do a lot of tests before and after studies. We use special fundoscopes, MRI, ultrasound. We'll look at the retrobulbar area of the eye and the overall eye structure. And we think that Russian cosmonauts should be part of those studies as well. This approach would help to preclude the possibility of us missing these changes in Russian cosmonauts because we're not using all this highly sophisticated technology to do our tests. Either way, if we have increase in intracranial pressure, it has to have some kind of long-term effects that we need to be able to observe. And Dr. Pachuev will be talking about that in more detail later. And I know that there have been some animal studies done in this area as well, and I would like Inessa to speak to that now.
He always sees me. Чтобы побыстрее сказать, я буду говорить
I will
всё-таки
speak Russian to make sure I don't take too much
Так
time.
вот, я хочу, поскольку у нас немножко было и по истории длинных полетов,
Since we have some historic experience of long flights, I will start with history. When I started working at our institute, which was very many years ago,
почти начало
that was almost the start of the space flights era, and I came from the area where we did not know anything about space-related factors. And when Valery Bogomolov asked me
то я
to
выразила
work
удивление. Я сказала,
in
«Слушайте, я
countermeasure
слышу, что у вас
subject, I was surprised
мышцы,
because I thought that muscles are
но для
mostly
тренировки
affected
мышц
in
нужны
long
просто
duration
силовые
flights, and
упражнения.
you just need to
Почему
make more,
космонавты у вас
have
бегают
more
вместо
exercise.
того, чтобы
Why
заниматься
cosmonauts
силовыми
run
упражнениями?
instead of
А,
performing
и
resistive
доктора, которые
exercises as
работали с
countermeasures? The
космонавтами,
doctors
и у
who
которых большой
worked
опыт,
with the
они мне
cosmonauts,
сказали,
experienced
«Название
doctors, they
А вы
told me,
учитываете перераспределение крови?
Ines, are you taking into account redistribution of blood?
Большие, так
A
сказать,
lot is
изменения
happening
в
in
сердечно-сосудистой
microgravity.
И поэтому вы
in
уверены,
vascular
что силовые
system.
упражнения
Are you sure that
показаны
resistive
при таких
exercise
перераспределениях, когда уже
should be
имеется
prescribed
большой избыток жидкостей
when
вверху?
we have
Я была в этом
such
абсолютно
overload of
и
liquid in the upper part of
Потом
the
прошли
body
годы,
in
и
space?
я,
I wasn't sure about that. I didn't think about it. Many years later,
значительно опытнее
I
и
became much
больше
more
знаний
experienced and I
накопила,
got much more
а,
knowledge
увидела
about this.
преимущества той
I
тренировки,
saw
которая не
the
мной была развита, не мной была
benefits of
инсталлирована,
the
и этот вопрос для меня ушел.
of the countermeasures
Ну,
as
прошли годы, и
running,
вот
and I thought
этот
everything was
вопрос
fine.
вдруг снова
But then
всплыл.
later on, this
И
question
когда я
came
говорю,
up
что вопрос
again.
ушел, он не
Many
уходил
years
совсем.
later,
Он всё
actually,
равно
that
у нас витал.
problem
Это
was
то, что говорит
lingering
Валерий Васильевич.
somewhere
Мы всё
always.
время
This
об
is
этом
what
думаем. Вот такие,
Dr.
да,
Bogomolov
мы
was
знаем,
saying. Yes,
что организм
we know
защищает
that
мозг в первую
the body
очередь, во
is
всех случаях.
protecting brain,
вот эти
first of all,
перераспределения,
and such
они
redistribution of
как-то
liquid in the body
коррегируются,
is corrugated.
как-то к этому
The
привыкает. Но
body
тем не
will
менее,
be
вот
adapted
эта
to the
всё время
new
настороженность,
state. However,
не
we're
будет ли
always
в каких-то
cautious,
случаях
and we are wondering
прорыв
whether in
этих
some
защитных
cases
механизмов
such
не будет ли повышения
protective
тех
mechanisms in
проблем?
the body
У
would
нас было.
fail, and there
И
would be some
поэтому, когда
problems.
мы,
We did have
я не
problem
знаю,
like
насколько
that.
известна
I'm not
здесь
sure if you're aware
премотологических
of
экспериментов,
primatological experiments in flights of Bion
отлетали 12 обезьян.
satellite. We
Эти
had
обезьяны летали
12
по 14
monkeys,
суток,
14
учетом,
days at a time
с учетом
in
коэффициента
space,
пересчета
taking
на
into
жизнь и
account
так далее. Это
coefficient
где-то
of
порядка 3
animal life that will
месяцев.
be
И без
about
без
3 months of
профилактики.
human life without any
Поэтому,
countermeasures beforehand.
один из экспериментов, который
And
был
one of the
поставлен на
experiments
обезьянах,
that we had
это
with
прямое
monkeys
измерение
was
внутричерепного давления.
just direct measurement of
данные были
intracranial
получены и опубликованы.
pressure. The data was published.
Мы получили там
We
очень небольшое
got
повышение
some
внутричерепного
small
давления
increase
в
in
момент
intracranial
перехода
pressure at the time
к
of
невесомости.
transition and
В пределах
adaptation
ни разу
to
мы не видели,
weightlessness
чтобы это повышение
within
выходило
limits.
за границы
We never
нормальных,
saw any
нормативов внутричерепного давления. Да, у этой обезьяны давление
abnormal
повышалось,
increase.
но оно было внутри
It was still
нормативов
within the
обезьян.
norms for monkeys
Внутричерепного давления.
for
И более
intracranial
того,
pressure.
оно держалось очень
And
короткое
it
время.
was just for a short
Затем
time, very short time.
давление
After that, the intracranial
и было
pressure was
стабильно, поскольку это было
stabilized,
прямое
and
измерение.
we were directly
Оно
measuring it. It
измерялось
kept being stable. We were measuring it constantly, periodically.
неизменно в течение
And
всего времени
during the rest of the mission, the pressure was normal, it was fine.
Но теперь другое. Я
Now,
вот сама теперь просто слушаю
I am listening
то,
to
что
everything
говорят
that is being said by specialists
тем данным, которые получены у
based on
космонавтов.
the data
Я
that
обратила
cosmonauts
внимание,
were
может быть,
providing
это
us
мой
with.
английский, что я не уловила
Maybe
правильно.
it's my English that I didn't quite understand.
Изменения
Women
особо у космонавтов,
did not
астронавтов, а у мужчин.
show
И
much
тут даже
change.
как-то
Men
сказала, что, может
mostly.
быть, тут
maybe
различия гендерные и
there is
так
some
далее.
kind of gender
Вы знаете,
difference
я занимаюсь
that also plays a
профилактикой,
role.
и в связи с этим
I work with the countermeasures. I never worked with the sports physiology before I started working in the space industry. But when I started working with countermeasures, naturally I was really aware of the issues of the space of sports physiology. And I know that people who work with resistive exercise, they do have this problem. They have visual problems. They even have retinal peeling problems. And I still have this question before me. And I know if I have a question, I'm supposed to answer this question. I think we will start dealing with it eventually. I was asking my colleagues, my American colleagues, whether there has been an attempt to analyze the changes that were observed in astronauts, compare them with the level or correlate them with the level of resistive exercise in flight. Maybe there is correlation. Why I'm talking about it, I am carefully listening to everything that is being said. Is Leroy here, Leroy Chow? We attended one of the seminars. Remember, it was devoted to vestibular subject matter. Leroy said that those issues started occurring when the US system moved from IRAD to ARAD. People who don't know that probably don't see what the difference is. ARAD loads are much greater than IRAD. Leroy said, I don't have those changes because fortunately I was flying when ARAD was not implemented on ISS yet. You know what? That's all in the air. Those loads on ARAD, the new loads, higher load, became effective for muscular degradation prevention. But I am afraid that they are being harmful otherwise. We are treating one thing, even pharmacologically sometimes we may damage something else. And we resolved it on our side. We will be performing experiments, long-term standard exercise. We just did not have resistive exercise for the loads that will be comparable on ARAD, but we will be doing such experiments. We will get some data, and maybe we will be able to prove or make some other conclusions. That's all I wanted to say. But I also have a small comment on something that has a direct connection with what we are talking. For a long time, we have not seen anything. We thought everything was fine in weightlessness, heart, internal organs. I would say as a simple human being, internal organs, they seem to be okay, right? We talk about missions, space missions today, and I am surprised that we still have some areas that are mystery to us, and it's very good that we actually encountered problems and we started thinking about something else besides heart and vascular system, the central nervous system. The brain can be probably affected by weightlessness. And dear physicians, I'm a physician myself, that's why you shouldn't be upset with me. I think you often say, okay, this is science. When I say, the cosmonauts are saying, oh, this is science, I understand. I let them do this because it's okay. But when physicians are saying that this is just science, I cannot forgive them. I work with the central nervous system, and I'm working with cosmonauts who are undergoing long-duration flights. Some of them I am registering in the first days of their mission. Sometimes it lasted up to a month. Ataxia of such levels, cerebellar only. I'm wondering what exactly is happening to them. I should not be asymmetria. I am talking at it as a physiologist. Maybe the sensory systems are getting out of whack. Maybe, or maybe not.
Inessa, could I just break in here?
I'm finishing. Okay. Вот что я хочу сказать.
What I want to say, I am actually pleased. It doesn't sound good, I know, but I'm pleased that we actually have some symptoms that made us all stop and look around. How much we still don't know. You're talking about MRI. You're looking at the eyes. How about the head? How about the brain? We have such amazing tool. We can check out the brain. Have we checked the brain for our cosmonauts? No, we have not done that. And so forth. Thank you for your attention.
Thank you very much. So let's go even further into not brain and heart, but let's go into the genomics. I think we need to touch this element as well. So I would like you to come forward and educate us what we could learn potentially from genomic studies to resolve that issue.
Yeah, so thank you. I think I'll try to be brief. I think there's not a lot of work that's been done, but there is one paper that I would really commend to everyone. It was actually published last year. The first author is Sarah Swart, and Scott Smith is the other author. And essentially what this paper is looking at is it's looking at the one-carbon metabolism pathway. Peter Norska's nodding his head because he's obviously looking at this work quite closely. And what this work is trying to understand is at a genetic level, why do some astronauts, and I think, Ben, maybe you can comment as well, I think predominantly I'm aware it is predominantly males at this point. Of course, there is a skew in the number of females versus males flying, so this is a confounding factor that we have to, of course, be aware of. But not everybody experiences the VIIP problem. And so in this paper that I was mentioning by Dr. Scott Smith, actually blood was drawn. It was a very beautiful study. It was a longitudinal study done with blood draws prior to missions and during missions and after missions. And a number of analytes were looked at. And there were 4 or 5 key analytes. One of the analytes was homocysteine, and it was found that in astronauts that had experienced visual impairment, that the homocysteine levels were significantly elevated. And there were other related metabolites in the same pathway. And so this is a clue, perhaps, and is, to borrow Ben's language, I don't think we should actually jump to conclusions that we unequivocally know the answer to what's causing this. So the sort of the follow-on comment, the corollary to what I'm saying here is I think actually we need to go beyond what Dr. Scott Smith and colleagues have done. I would actually argue quite strongly that a lot of resources, genomic resources, should be thrown at this. Scott Smith and his team did a targeted genomic study. I actually think that a more comprehensive genomic study should be done. This is done in medical schools all the time, where cohorts of affected versus unaffected individuals are looked at. And again, to paraphrase what Dr. O'Malley was saying yesterday, we don't actually completely know what we're going to find here. We don't really know the answer, so we should try to look at everything, basically. So I would argue my urging to this group would be that this is actually a classical situation where we've got a group of unaffected individuals. They all more or less experience the same spaceflight environment in terms of elevated CO2 levels, microgravity. The US astronauts, I think, are all fairly, from my understanding, is they're fairly highly scheduled, and so they're more or less, I think, within a fairly small tolerance bar, undertaking the same exercise regimen. So I am arguing quite strongly that this is a situation that would be very amenable to a more holistic genomic analysis, where we might find other pathways other than this vitamin B12 and this folate pathway that Dr. Scott Smith has looked at. Let me see if I have any other key comments. The other thing I would say is, perhaps when we do this work, obviously we have blood. As Dr. O'Malley mentioned yesterday, it's critical to look at this in an integrated way. So you shouldn't just look at DNA. You should actually look at protein and RNA, and then you are more likely. And then when you overlay the data at those different levels, you're actually more likely to be able to make sense of what's going on. And Ben Levine always likes to remind me that this has to somehow map back to physiology. And so if you're able to look closer to the physiology, and of course the proteins, being the worker bees in the cells, are actually closer to the physiology than the DNA is. So I think that's my contribution, but I would close by really highly recommending, if you have not seen the Scott Smith paper, it's the first foray into this area. I think it's an excellent piece of work, but I think we need to do more. And Peter, you're nodding your head, so yeah, thank you.
Thank you very much. We have Dr. Baskin on our panel, who's the neurosurgeon on the VIIP panel that is trying to evaluate the cause. Even if I become unpopular among the astronaut corps, at least we need to talk about measuring the intracranial pressure, pre-flight, post-flight, maybe in-flight, invasively, non-invasively. So I would like to get your take on that.
Well, thank you. It's a pleasure to be here to speak to this esteemed group. I mean, I think that having pored over this data, astronaut by astronaut, I'm struck by several things. One is the heterogeneity of the response. There's certainly some astronauts that don't get any of this. There's some astronauts that get a little bit of flattening of the globe and a refractory error, and there's some where you can see a lot more. And we have no idea why one gets it and one doesn't. So I think arguing for genomics, proteomics, metabolomics, trying to really get down to what is the basic phenomenon and why is extremely important. But we also don't really know that much about the basic phenomenon. And as a physician and a scientist, the problem is we have a low N. We have a low number of subjects. So several astronauts, some of whom I've actually performed lumbar punctures on when they returned to Earth, had persistently elevated intracranial pressure, around 28, 29 weeks later. You know, why should that be? Even if intracranial pressure is the event that's primary, and there's a lot of speculation about that. It could be low pressure in the globe, it could be many different things. Why should it remain elevated for several weeks later? So we're struck with a very important phenomenon that's becoming more and more apparent. We're facing longer space flight. So, you know, if you send a monkey up for 2 weeks, maybe nothing happens. If you spend them up to 3 months, maybe they have an adaptation. But if you're up for 6 or 9 months, you know, the problem could be potentially more serious. And as a neurosurgeon, we're learning more about long-term consequences. So if there is a long-term change in the intracranial pressure dynamics, this could lead to, you know, downstream effects on the health of our astronauts decades later. Just like in America, we have this problem now with football and all these football injuries. And now 10, 15, 20 years later, these individuals may actually have an increased incidence of dementia and other cognitive problems. So we have an obligation to our astronauts to study this in a comprehensive way. The bottom line, though, is what is happening to the intracranial pressure. We really, really don't know. We have lots of speculation, we have lots of indirect evidence, and so we must find a way to monitor intracranial pressure. There is a very famous paper published in the literature of a mountaineer who actually climbed into high altitude and actually had implanted intracranial pressure monitors in the individuals. And this was in the 70s, where the technology was really very, very poor. Now, of course, the technology is much more sophisticated. That's the most aggressive approach. There's been an emphasis to try to develop non-invasive ways to measure ICP. And obviously, that's kind of a good thing to do on Earth. We can do it with MRI. We can even do lumbar punctures on Earth. But we really need to be able to measure it in space. And so I think the problem is we have a very interesting and complicated phenomenon. We have all sorts of pieces of evidence. We have all kinds of theories. But until we comprehensively develop a protocol to measure intracranial pressure at as many points as possible, we're going to still be speculating an awful lot about what the real cause is. At a minimum, I would argue you could measure intracranial pressure on Earth before the astronauts leave, because maybe there's maybe it's something as simple as that the people who develop the syndrome carry borderline elevated pressures before they go into space. We don't know. We don't measure that. And certainly measuring the pressure when they return is, again, it has to be volunteer. You're not going to force the astronauts to do lumbar punctures, but lumbar punctures these days are almost an outpatient procedure. But we need more data, and we need more data about intracranial pressure. So whether it's invasive or non-invasive, whether it's only on Earth or on Earth and while in flight, we desperately need this data to make any sense out of the phenomenon that we're seeing.
Thank you very much. Yeah, and the medical community is heavily debating and discussing this issue, especially next week. I think we will have it on our agenda in the international working groups. Having now gone through the scientific operational side of the VIIP problem, of course, at the end, we want to refly astronauts who may have shown those symptoms. There's always the question of recertification of an astronaut. We need their compliance to buy into certain studies that we gain the data. So I would like to know from Dr. Pochuyev, who is member of the Multilateral Space Medicine Board that is dealing with recertification issues, about his take on, can we fly an astronaut that has shown and demonstrated those signs? How do we deal with certification issues related to that?
Thank you very much for your question. A question of certifying crew members is very important, and this is one of the it should enjoy the first priority. What is certification? This is making a decision. This is an expert decision that will affect either astronaut or cosmonaut. Usually, medical expertise is done by a number of very knowledgeable physicians and scientists, and we need to make sure certification is done accurately. We need to make sure that changes that have been observed are well known, and we know how they are going to demonstrate themselves in the future. If we look at the agenda now, the first question would be a definition of syndrome or problem. We still cannot define accurately whether we are just talking about some changes that occurred as a result of long-duration flight, or maybe it is a real syndrome. I was very intrigued by Mr. Kramer's speech when he was talking about subjects of research. He said that there were a lot of hypotheses voiced out in the very beginning, because we were trying to find the causes that may be the reason of those changes. And then a new hypothesis came up as a result of studies. So what are we having? We have a change in visual acuity, right? Also flattening of the apple of the eye, then also the nerve changes and retina changes, and also the disc of the nerve, optical nerve change. In fact, we have not observed such important changes in Russian cosmonauts. For example, changes in the optic nerve were observed on the 14th or 10th day from the beginning of the flight, and ultrasound would be necessary probably, or some other measures to look exactly and document and objectively assess what was happening, to make sure that we really have some data, to have statistics. However, it was a serious problem because it was resolved later on. If we did have such occurrences that would really alert us, we would, I'm sure, have enough research and actually have some statistics by this time, but we really did not have that. The fact that we made a decision to cooperate with our international partners and study actually the changes that we are observing also, including Russian cosmonauts, to make sure we lower the risks for changes in the optical nerve in the cosmonaut astronaut crew in general. It is true. We are also introducing the new methods of research, which will be ultrasound. This will be tomography, and also new methods of checking vision right before flight and after flight. We will be doing that. Yes.
3 Tesla МРТ, да.
Also, 3 Tesla MRI.
That would allow us to do the study on the molecular level and identify changes that can occur in crew members. But I want to point out that we shouldn't really forget about the ethical point of the subject, because we're working with living human beings, and our studies may have their effect. We're talking about recertification. Recertification means we're making decisions about their future. It can be positive, it can be negative. We talked about various criteria that would impact disqualification of astronauts or cosmonauts from cosmonaut corps. And we talked about this subject over 30 years. We know that there were some disqualification criteria that dealt with candidates' health, but we weren't very consistent in implementing them. And we also noticed that every time we would introduce a new test, a new medical test, that would help us identify medical problems, the more people we would disqualify. And I fear that the same will happen now that we're looking at these new ways of testing people for potential VIIP problems. So at this point, I want to caution you that if we're doing these tests, we should do them the goal of furthering our study, furthering our knowledge. It is very difficult at this point to make any forecasts based on those tests. Thank you.
Yeah, we are running short in time, and we need to meet the timeline to connect to Antarctic Station. But I still would like to open the floor to the audience to ask questions to the individuals. So if we could hand out some microphones. Yeah, they're just coming. Let's just hold on for a minute. Back there is, and yeah.
David, do you want to go first?
I'm a neurointensivist and vascular neurologist at Baylor College of Medicine. I just want to make a few brief comments. First, we don't know exactly which of the astronauts or cosmonauts are going to develop this problem, but if I can make an analogy, in the neuro ICU, when we have patients that are at risk for intracranial hypertension, we institute some basic prophylactic measures in order to attenuate the possible risk. These include making sure the carbon dioxide levels are within the normal range. And as you know, in the International Space Station, the carbon dioxide levels may be up to 10 times higher. We always put the patients at about a 30-degree angle to facilitate fluid shifts out away from the brain. On the International Space Station, they're always in about a -6-degree head-down tilt position. Furthermore, we would avoid any sort of muscle tension in the abdomen. It's well known that Valsalva maneuver will elevate the ICP. And when we have invasive catheters measuring the ICP and someone coughs, strains, is constipation, the fluid will drain like crazy into out of the brain. So I made a comment about the ARED, and that is something that we should pay close attention to and look at the exercise regimens.
Volker, I'm Chuck Oman, the NSBRI's sensory motor team lead. Following up on this point, are we really looking at the exercise techniques that ARED users are employing in flight? Certainly, it's very technique dependent, but I think people should be aware that there is a clinical literature on retinopathies, papilledema, and so forth in weightlifters and the players of wind and horn instruments. So as a significant cofactor, I think we really should consider that and make sure that the astronauts are aware that that valsalving during weightlifting may have some negative consequences.
Maybe just as a quick feedback, of course, the countermeasure working group is taking that into account, as Inessa said. Also, we now have the opportunity to have a real-time connection to the crew, scheduled connection to the crew, to monitor what they're doing in terms on ARED and provide feedback if they're doing the right thing at the right time. So we're trying to go along that path. There was Cass.
The space medicine is very dynamic, and we haven't solved the 20th century's homework of what to do with the space motion sickness, and now we have the 21st century problem of VIIP or papilledema. And Dr. Baskin's comment is very interesting, and I believe that if Dr. Carwin is to fly next year, he will be happily submit himself to your idea of having a pressure sensor in his body, or maybe not. Okay, and the flight surgeons have a fear that my crew member could be the next case, and could be the most severe case of the papilledema. And the basic thing is that our fear is not in the ICP, because our crew member will not suffer from the ICP problem post-flight. It's the eye problems. And I understand that Dr. Bogorov comment that his suspicion about the resistive exercise device. But looking at the cases, I have a feeling that, not necessary. And the question to Dr. Baskin is that why investigators are looking into maybe too much into the ICP problem, why the effector organ is the eye, and why people are not looking into the eye?
Well, I think the answer is they are. There's a tremendous amount of research and thoughts about ocular hypotony, that the main pathology is not elevated intracranial pressure, but lowered intraocular pressure. And I think some of the sophisticated MRI protocols and even some of the sophisticated on-site scanning techniques are going to try to get at that. However, I'm not so sure that it isn't a combination of both, because we do have this data where these astronauts seem to have persistently elevated intracranial pressure when they return to Earth. But in the end of the day, you're absolutely right. What we need to be able to do, and it would have to be in volunteers, there are many ethical issues which has been brought up, is to try to monitor all these factors real time. Monitor the intraocular pressure, monitor the intracranial pressure. And this has sort of been my big bailiwick, but I mean, there are now devices that can be implanted, that can be radio telemetered, and obviously there's some risks, small risks to doing this. But I think the reward would be huge, particularly if everyone in this room, I think, believes in the future of a space program for centuries. This is a problem we're going to have to figure out if we're really going to go to the stars and we're really going to be in space in any real, in any significant way. So, I mean, your comments are well taken, And I'm not here to tell you I think it's intracranial pressure for sure. I'm here to tell you that I think we must find that out and must have good data, both on the intracranial pressure, the intraocular pressure, the ultrasound, the OCT, all of these things that are being instituted. And I, for one, as a scientist, would love to see international collaboration and coordination of these efforts, because we really don't have that many astronauts, and we need a high number to really make sense of this scientifically.
Ben, you wanted to?
Я бы хотел, чтобы правильно, так сказать, понимали.
I just wanted to clarify something. I'm not in any shape or form against using ARED training or ARED exercises. I'm just talking about the exercise modes that are used with this trainer or with this machine, especially in those cases when a person is doing high-load exercises with changes in their breathing, when they have to hold their breath. So that's very important, and that's something I wanted to emphasize. But the trainer itself, ARED itself, is a wonderful tool. And of course, when we prepare our cosmonauts to work with it, we tell them about all the techniques that they should use and that they should be careful when they're working with it. Thank you.
I think that there's a couple of points that I'd like to make about this discussion, and the first involves the case definition. So the question was raised about what defines this problem, and is it a acuity defect? Is that what defines it? I mean, that's what our flight surgeons are using. You know, you have to have a certain amount of corrective error that persists to define the case. But I think that we all really need to agree on what that case definition is, because, Graham, I don't think it's an either-or phenomenon. I don't think people either develop it or don't develop it. It's a gradation of how much corrective error there is. And I think that if we spend too much time worrying about you either have it or you don't, you'll miss the fact that it's a continuous problem. And that goes directly into how we define whether someone has it or not. And then that leads downstream into, you know, if you have it, and if you have a refractive error, then what are the secondary imaging and other abnormalities? On the other hand, if you don't have a refractive error, but you do have a change in your MRI, do you have the visual impairment problem? I mean, I think that that's something that we need to define. I would also like to emphasize that it's really important. The leaders in the field of intracranial monitoring, of intracranial pressure monitoring for hypertension, like Mike Williams from Baltimore, have taught us that it's not just a single point measurement of ICP that's important, that it is continuous measurements. And in fact, at night during sleep is when many of these patients have the biggest spikes, whether that's because of sleep apnea or changes in breathing or who knows what, but that's what really defines the patients with the worst syndromes. Very high intracranial pressures at night. So we have to be a little careful about the single point measurements.
We have to be careful with time, because we are stuck there. Dave,
thank you, Ben. I was actually going to say, for those of us gathering data on the space station, given the uncertainty and the potential heterogeneity, looking at CO2 and other things won't be enough. You probably we want to maximize all the data the astronauts are willing to give us. And many of us have data sets that may seem orthogonal to this, but you just mentioned sleep and circadian biology. The hypothalamic area has a potent control over intraocular pressure also. The data that I and other investigators have now from 20-some astronauts coming down regularly throughout missions could be, through IRB accepted procedures, made available to those of you studying ICP to just mine it to see, is there anything in there that tells us who's getting this? Is there anything unusual about their sleep-wake cycles or their performance levels, or anything that we know or that the astronauts rated or gave us that would help you? So the question is, how can we help you by just providing data that could be mined? It's low-hanging fruit. We've already got it. Why not use it?
I suggest that we stop at this point in time. I see that there are still some burning questions, but let us move outside, enjoy the luncheon, and tag up on a personal level to clarify open issues. Thank you very much. Thank you to the panelists.